Hello, everyone. I'm sure lots of you are all filing in. Give you all a couple of seconds to join us. Welcome, everyone. Okay, everyone can see my screen, okay? Perfect, okay. Well, thank you everyone for joining the new installment of the Suvera webinar series. We were just reflecting before everyone joined. We've only just finished QOF, and I'm sure some of you still are living with the scars and nightmares of what just happened. And we're already back here again talking about it again. So you all must really love this topic. We certainly do. But we're really glad to welcome you today, and this is one of the most popular webinars that we've had so far. We've got a record number of registrations. I'm actually joined by two very distinguished guests today as well. I've got Amy, who leads all of our planner product, who she'll talk a bit about how that can help you with your practice later. We've also got Chloe joining us for the first time, who leads a team of pharmacy technician managers and also leads all of Recall for a 20,000 list size. And her goal is indeed to hit QOF by Christmas, so no pressure there, Chloe, but we'll be hearing from her a little bit later on as well. Just some very light housekeeping for those who've not joined us here before. Please do pop your questions in the chat. We will have a dedicated time to address those questions at the end, so just feel free to pop them in whenever you wish. The slides will indeed be shared, and the recording, some of it will be shared, and just to kind of explain why, some of the parts of this webinar will be a look at our product and how it works beneath the hood, and we would prefer not to share that out massively widely, but you will see all the exclusive demos here live. If you've got any AV issues, please just log out and log back in, but without further ado, we'll dive into the content. So for those who've not been and joined us here before, it's a real pleasure to host you. My name is Dr. Will Gow. I trained as a medical doctor in London. I'm proud to be one of the sort of early NHS Innovation Accelerator Fellows, and we love all things to do with technology and helping primary care. But I wanted to kind of take you back to the origins of sort of where it all began and to really set the context for this conversation, which is we know that there's been a real growth and burden of long-term conditions. So to kind of paint the picture, 1 in 4 adults in England have a long-term condition, and that takes up 50% of all appointments in primary care, a staggering amount. And the trajectory is only going to sort of increase and become more complex. And so for the 65 and plus category, by 2035, which really isn't that far away now, there's going to be a 2-fold increase in those who live with 4+ conditions, so up to 17%. And those living with 3+ conditions, they'll be up to 66%. And I thought I'd kind of pause there and reflect on that, because it's not just the sort of the growing aging population that's going to be an issue, but it's also the complexity of coordinating and arranging that care, which is what we'll discuss a lot about today, which is how do you actually deal with the multi-conditions in the world of spreadsheets that we have. But I thought I'd actually try to bring it back down to why we're seeing so much emphasis on long-term conditions. The numbers start to lose its meaning after a while, to me at least, but £115 billion gets spent a year on managing it, which is 70% of all of the primary and acute care spend. So a massive amount of money. And the policy documents, which we'll go through in detail in a moment, really does point towards something that's repeated a lot, which is proactive and preventative. And certainly at Suvera, we hold a belief that, you know, without new capacity, then technology improvements are really essential to driving that productivity. But very, very briefly, why Suvera and why do we care so much about this topic? Well, for the last sort of 5 years, we've been delivering proactive care in general practice. For those who know us, we've been delivering a virtual clinic where we actually manage around about 200,000 active patients with long-term conditions. And over the years, we've very proud to say we've collected some awards along the way. Last year in particular, we won the HSJ Awards for reducing health inequalities, and that was all to do with the software and the platform that we've designed. And we're also going to take some of the learnings that we've had from being selected as one of the pilot projects as well for the new neighbourhood programme, which is a collaboration between primary care, voluntary care sector, and Suvera. So we'll share with you some of the learnings there. So this is the sort of the very quick agenda. We'll go through the policy changes and the rather provocative title of QOF by Christmas. We know it's a very hard feat. We'll then hand over to Amy, who will give you that exclusive demo of how the automated recall technology can help your practices. I'm really, really proud to say that we think this is one of the most robust and most advanced technologies out there in the market. And then last but not least, we'll hear from Chloe on her real life experience actually managing recalls for that 20,000 patient population. So really starting off with where the NHS is heading. So the where is the 10-year plan, and we've heard this numerous times about prevention, community, and kind of moving it all closer to home. But only recently have we started to hear the hows, and that's been the sort of the documents that have been published recently. So we've got the QOF, the DES, and the Neighbourhood Health Framework. I won't blame you if you didn't spend this sunny bank holiday weekend reading every document. There is quite a lot to get through, but I would say the unifying feature that seems to tie this together is knowing your population and using data and acting proactively is the thing that ties it all together. And we'll go into a bit more about how it does that. But the meatier subject that came up in the first instance was QOF. So again, we'll share these slides with you afterwards, but there were a few new indicators and some changed indicators as well. So in terms of the new indicators, they've amalgamated the coronary heart disease and stroke indicators into one to form one new CVD target. This is quite a meaty target, so 61 points actually falls into this. So it's actually one of the second largest in the whole of QOF. And interestingly, they've removed the frailty part of it, which we'll come back to in a moment why that's important. The second target is heart failure. So they've introduced a 4-pillar therapy for heart failure. One of the things to note is that it does require the patient to be on all aspects of it. So there's quite a bit of titration involved. I think that's why they've reflected the thresholds to be fairly low at 20% to sort of start earning points for it. But one of the things for people who are in charge of recall on the call is this will inevitably mean several appointments for a patient. It will unlikely be a kind of a one and done approach. The next factor is the diabetes one. So some of you may be familiar with the sort of 8 care processes, 9 care processes through your local incentive schemes, but they've tied it into QOF this year. And our take on it, having managed a lot of diabetes patients, that this will be a test really of your coding ability and the ability for your whole team to basically follow every single sort of template. We will have tools later on in the call that kind of helps you with this, but it's an all or nothing target. So you need to make sure you check every single one for the patient to be ticked as complete. And then lastly, in terms of new targets, you probably would have heard about this already, but there's 18 new points that have been brought into QOF, and that falls into obesity. So that's to do with referrals to weight management programs and also for discussing different pharmacotherapies for obesity. Interestingly, it's not a sort of a clinical target. It's not like a sort of a change in BMI. It's mostly just kind of directing patients to the right place. So it should be one which is fairly addressable. But one thing that is, again, a common thread throughout all of this is that the coding and that aspect of it will be really, really important to make sure you get the maximum amount. There have also been some changed indicators as well. I won't go into every single one of them, but I wanted to point out 2 that stood out. The first one was the hypertension target. They've now removed the frailty part of it, but they've left the points unchanged. So it means that these patients are still on your register, but they're just not forming part of your target. So in other words, you're actually getting paid for the same amount of work spread across fewer people. So that's a good thing. The other thing it also means is that you don't have to put in the exclusion codes for frailty patients anymore. But I think the subtext to both the new CVD target and the hypertension target is that it talks a lot about in the new neighborhood transition that frailty is a massive part of it. So it is my prediction really that they're trying to partition it out so that it becomes a more standalone target for the neighborhood project. And then lastly, just touching on vaccination and immunizations, there's a new dual calculation that's been introduced. The long story short here is that for practices that were previously not performing to the highest amount, rather than it being an absolute floor of needing 80% plus to unlock the funding, you are now able to unlock the funding from just a baseline improvement, which basically rewards people from showing improvements. So the key thing here, if you're a practice that has not been previously achieving the vaccination immunization points, is to really have a clear, coherent baseline of where you were before and really track towards progress on that. But what I really wanted to do is sort of tie together the 3 kind of documents and share some of the themes that came up and what was most important. So for the QOF targets, if you have been following the different changes, now 70% of all of the revenue that comes from QOF are now in cardiovascular disease. And again, that points towards one of the building blocks for the 10-year plan, which is kind of moving towards prevention. In terms of the PCN DES, the main thing to call out here was they've obviously repurposed sort of the capacity and access payments and moved it into primary care budgets for the GMS contract. And it's also increased the flexibility for ours as well. So you're able to use it for more sort of GP reimbursements now. But the core thing that they emphasized is that population health and risk stratification is now mandatory. And they've kept it slightly vague on the details of what kind of risk stratification tools they mean, but we've prepared some guidance for you to support you with that. But I think when I was reading through it, the thing that stood out to me is that they've left the DES contract fairly thin, and they've started establishing a really clear transition towards the neighborhood health. And the neighborhood health talks about how the integrated neighborhood team, which is a cluster of sort of different parts of the community, are coming together to manage a defined population. It really struck me that the emphasis now is which PCNs are really putting themselves forward to be influencing those conversations. We ourselves are not a consultancy firm, so we're not going to give you sort of clear advice on how to position yourself for neighborhoods, but what we can do as a technology company is give you the tools to do so. And one of the things that we think really underpins that conversation of PCNs to neighborhoods is data. As data and the population health is going to be really the foundation towards all of that. And so some of you would have kind of seen this in the documents, but what you're seeing on the right-hand side is a diagram of where the commissioning flows will go in over the next couple of years. And I've tried to break it down into sort of what do we need to know today, which is the green layer, which is what we're doing at practice, and also what do we need to prepare for tomorrow, which is the SNP and the multi-neighborhood provider level, and also the IHO level. In terms of what you need to achieve today, certain things like QOF, hitting the LES targets, and also things like hitting the CQC high-risk drug monitoring, those things are all really, really important, and we've built that into the planner product that you will see a little bit later on, but these are things that you need to do today. And you also need to have some element of risk stratification in accordance to the PCN DES. But the reason why I showed this diagram in this format is, again, to the point of that the building blocks of a successful neighborhood team relies upon every single practice here on the call today. They will need to know the ins and outs of which patients are well engaged, which patients engage to certain modalities, which ones are most at high risk. And so the emphasis that we want to kind of provide here today is that even though you're planning for right now, which is the QOF year ahead of you, everything that you do will future-proof you for the neighborhood transition that's going to come. And so explicitly in the documentation, they've already said the expectation for the neighborhoods is to focus on things like frailty, end of life, and multiple long-term conditions. And so not just sort of Suvera, but a lot of people who have been focusing on this space are seeing that the neighborhood framework documentation is slightly vague in terms of what's going to form it, and they want to leave up to the local kind of area to decide it. But we fundamentally believe that if you can lead with data and show that you're a proactive provider, you will be more likely to lead the conversation than be led in that conversation. So that's what we want to provide you. And so one of the promises that we want to do is that as the guidance evolves, which it certainly does, and more documents will drop, the planner product that we've kind of designed will evolve alongside of it. So that was a whistle-stop tour of sort of some of the new policy changes and some of the QOF changes as well. But we really wanted to tackle this question of how do you get in front of the problem? And like I said, some of you may have just gone through this and think this is completely unachievable, but we believe that there is a method to do so. So the first thing to tackle is the different types of recall methodologies. There's the month of birth recall, which has its sort of advantages and disadvantages. The main advantages we can see is that it's a fairly simple and straightforward way to distribute your patients evenly, and that patients do build some familiarity with the recall times in the year. They'll know that by their month of birth, they have the best birthday gift of all, which is a blood test or a check-in with one of their clinicians. The disadvantages, of course, we've mentioned this a few times already, but people are left uncontrolled for a longer amount of time. It does leave a bit of an end of year rush as well, because some of those high risk patients are left towards the end. Myself, I'm a March baby, so if I was someone with complex long-term conditions, I might not get seen till right at the very end. And so there are some sort of clear disadvantages to it. The other main one is risk stratification. And as that's been mentioned in the DES, I wanted just to spend a little bit more time on it. So on the right-hand side here, some of you would have come across this already, which is the UCL Partners risk stratification. This has actually been mentioned in NHS England sort of policy in the past. So this is a recognized stratification tool, but there are several others that you may be wanting to implement. This one looks at per condition and it breaks it down into priority groups. Fairly simplistic, and what you can do is you can aggregate multiple conditions into one priority group, which we show you how to do later in the planner product. But the advantages of this is, number one, it's compliant with the DES, where it asks explicitly for risk stratification, and it also future-proofs you for when neighborhoods need to know that sort of highest risk layer. But it also does a few things, like it addresses the question of health inequalities, because you are indeed seeing those sickest patients first, and you're reducing the amount of time someone is left uncontrolled in your practice. The main downside that we hear quite a lot about why they don't employ a risk stratification is that it doesn't always capture every single patient, and it requires a fairly robust kind of system in order to do it. When you compare it to month of birth, it's quite straightforward. It's just divide by 12, whereas risk stratification, you do need a tool that does everything. And so that's part of the thinking of what we've brought into the planner product later. So we'll show you the flexibility and how it can do that. But I thought I'd try to kind of tie it into a more of a visual look at it. So forgive my very basic color coordinations, but broadly speaking, for most practices, and this is what we experience doing recalls ourselves, is that you've got the high risk patients, moderate risk, and low risk patients. And I've segmented it into the different quarters. Obviously, we're in the first quarter at the moment, with January, March being that quarter where you can do sort of more of the mop-up work. If you were to try to invite most patients into the first 9 months, the obvious question we have is, do we have capacity for it? And I'll touch on sort of some of the tips we can provide later. But you can see how evenly distributed that is. So you have some of the high-risk patients coming in later in the year. Now, if you compare that to risk stratification methodology, which is something that we encourage a lot of practices to do, you start to push all of the high-risk patients into April and May, and you have more time to manage these patients throughout the year. So it's the same patients, just kind of rejigged into a different format. What's really interesting as well is if you actually look at the seasonal variation. So we know every year that October, onwards is when you start to look at flu season, you'll start to look at vaccinations, and then the winter pressures start to rise. So if you compare the two different approaches, on the left-hand side, you're still dealing with high-risk patients that will inevitably fall into January and March. Whereas if you take a high-risk stratification approach, you should in theory be dealing with the lower risk patients in that kind of crunch time period. I will just pause there and say, having done this with a lot of different practices, it's not a one-size-fits-all approach. If you've been doing month of birth for multiple years and patients are familiar with it, I wouldn't radically rip up everything and change it all, because patients will disengage, and it actually, ironically, is worse for you. But you can start to see the visualization of why it's more advantageous to at least book patients who are higher risk earlier on in your flow. And you might be sitting there thinking, well, what he's done, he's just put 12 boxes into 9 and therefore magic solved. Well, to an extent, you do need the capacity, but we feel like there's a lot of technology aspects and coordination tools that can help you with it that isn't inclusive of capacity. So the first thing is multi-morbidity clinics. This is, I would say, a non-negotiable if it is to kind of increase your overall efficiency. So how do you make sure you cover as many conditions for that patient as possible in a single visit? The second thing which ties into that is the competency matrix. So you want to be able to ensure that your staff makeup is maximized to the fullest extent. So really seeing which clinicians you can upskill and really allocating the appointments to the right clinician so that you're not kind of underutilizing your staff to the fullest extent. Again, both 2 points are purely to do with coordination and not to do with introducing new capacity. The third that we see a lot is not having your outreach engagement attempts on an autopilot. So a number of practices we work with still are rightfully, because of the tools which are available to them, using spreadsheets, and they're tracking which ones have engaged, which ones have disengaged, who didn't attend appointments, and it gets very messy very, very quickly, and you're spending a lot of kind of labor hours doing it, and people slip through the net. And so having a tool that is efficient, automatic, will free those people up, which you can possibly upskill into a HCA role to help you with things like phlebotomy. Which comes to our final point, which is, from our experience, one of the key rate limiting steps is what practices often call the part 1 check, or the phlebotomy and foot check. This often is a bottleneck. So really identifying that early and planning ahead will allow you to sort of over invite those patients into the financial year. So those is just a summary of the different things that we've learned along the way, but we really strongly believe that having the right technology infrastructure is fundamental to ensuring these all work effectively. But yeah, really excited to kind of introduce you to Chloe. I think one of the things about new technologies is how does it actually work? And we wanted you to hear from someone who's lived and breathed it. And so Chloe is a great shining example of this. She leads a whole team of pharmacy technician managers, and she's also been leading recall single-handedly for a 20,000 list size. So it is an absolute pleasure to introduce Chloe.
Amazing. Thank you, Will. And thank you, Amy, for going through Planner in such detail. So yeah, I'm Chloe. I'm a pharmacy technician by background, and have kind of come into this experience of recall through kind of a contract that we had come up. So Will, if we can hop onto the next slide. So just to give you a little bit of background on how this came about for myself and my team. So one of our practices, the Maltings Surgery, they requested to have some support for recall, looking at their patients for kind of all of their QOF targets and ECF targets. It was quite a broad request. I think it was something I'm sure most of you in practice will know it's quite a challenge when you're kind of looking, especially at the beginning of the year, thinking, gosh, this is a lot of patients that we need to reach out to, a lot of appointments to be booked. We came into this slightly later in the year as well. So we came in sort of August, September time. There hadn't been all that much recall that had been put in place prior to us picking this up. Like with kind of a lot of different practices as well, there's not necessarily a clear plan for outreach, other than we need to contact all patients, we need to get everybody completed for their reviews. That can be kind of quite confusing, and trying to build a process for how to do that most effectively. It's a challenge, and I'm sure that every year, regardless of how many years we've done it, targets change, goalposts move, and so we kind of need to take that into consideration. Alongside that, so I'm pharmacy technician, but we also have care coordinators working on this with me. So actually there was some quite steep learning to be had with the care coordinators around, in particular, coding, which is I know, again, everybody will say there's kind of particular coding challenges that arise from completing different bits of recall, basically. So with this, it was kind of a mix of kind of delivering to ensure that we're meeting QOF targets, but also building a whole process at the same time. So starting from scratch, literally with a few Arden searches that we had to kind of work from. Will, if we can hop onto the next slide, and I will show you a screen that I'm sure many of you, or many people in your practices, will be used to seeing a monitor like this, where we have potentially some local spreadsheets looking at kind of the specifics of what we want for each patient, for each condition. That in itself is a bit of a minefield, what bloods are requested for each condition. One of the other things I know that kind of there's a lot of questions around is medication monitoring. Again, that's something that typically managed by clinicians, not necessarily care coordinators, so ensuring we had that documented. Arden's Manager, fantastic tool for finding patients, but that's pretty much it. So then you're kind of building and looking at the codes that you kind of want to have added to patients for the particular recall attempts. AccuRx, spending my life on AccuRx, and all of these things, as well as using kind of either EMIS or if other practices using System 1, it's multiple systems, multiple steps, nothing really joining up, no matter how hard we try. I'm sure that you've all got your own kind of spreadsheets and plans that you've been trying to follow, and it's never really that coherent. With this as well, I think everything being manual is quite a challenge. So that could be actually personalising SMSs, scheduling follow-up SMSs. So not just inviting once, inviting kind of a second time. That's a manual process. Sending out blood pressure requests, sending out requests for urine samples. It's just really time consuming. And the other thing to bear in mind with this is obviously we want to kind of utilise everybody that we have in the team. For care coordinators, that means that the work that they were picking up potentially would be different. So actually looking and reviewing the more complex patients, what bloods they needed, if they required medication, monitoring bloods at the same time. It's really difficult when you're trying to judge those patients and kind of distribute and delegate that work across the team. And there's no real single view of what a patient actually needed. You're always reliant on kind of checking your various searches, even if you've combined everybody on one spreadsheet, then following up from there. So then Planner comes around, and we're looking at, thank you, Will, multiple workflows. So all of those different screens, different processes that we were using, actually Planner brings about kind of a streamlined experience. So this is where I kind of really start to see a shift. For patients, everything becomes much more joined up. So they're getting fewer messages from us, fewer gaps in kind of, oh, we need for you to come in for your DOAC monitoring bloods, and then in 6 months' time, we're going to ask for you to come in for a different blood, and then 3 months' time, something else. So actually, we're providing quicker access for appointments, and we're identifying all of those different kind of bloods that are required, investigations required, follow-ups that are required in one hit. For clinicians as well, huge change, more time for clinical care. So actually, with the work that is kind of then delegated via Planner, where I can then say, actually, I will request for the care coordinator to order bloods for the 60 patients that we're recalling for month of birth for next month. Previously, there would have been a bit of concern there of, are we ensuring that all bloods are being requested? Are we ensuring that we are inviting patients for the correct type of review? A lot of that is now kind of not a concern, because actually the logic that's built into Planner, it will identify the different bloods that are needed. And it's kind of, with all of this in mind, it's not just about speed, it's about the consistency and the safety that goes with that. I'm sure that many of you in your practice will have colleagues that are picking up various different admin tasks, who are really keen to help support with your recall work, and you don't necessarily always have the time to document a whole process of these bloods for this condition. This, with Planner, this is kind of taken out of something that you have to worry about. And moving across, it's kind of going from various fragmented processes to something that is much more structured, everybody working from one planner. And that means that we're all singing from the same hymn sheet, which is key, because actually, as a clinician, I would like to know that a GP partner that I'm working with, a care coordinator that I'm working with, a respiratory lead nurse that I'm working with, actually everybody knows where we are for recalling patients. And next slide, please. So life with Planner. One of the big things for me is not having to send multiple messages to patients. So I know Amy's touched upon this previously, but actually, rather than a patient kind of experiencing SMS fatigue, they will get one message for all of the requirements that they need. And then when those responses come back, so for example, collecting some lifestyle information, smoking details, blood pressure readings, ACT scores, that all comes back through into Planner that can then get coded directly onto the patient's EHR. It's a really smooth process. We're not sending different forms. We're not sending different text messages with links for patients, which I think is huge. And not just coming at this from a kind of working in healthcare perspective, but actually as somebody that if I'm potentially receiving this message, or if one of my loved ones, in particular, my kind of elderly grandparents, if I send them 6 text messages, they're not going to pay attention to it. They'll think that one is cancelling another appointment. It's very confusing, whereas this is kind of everything laid out in one message. It's consistent every time. So we're not going to have differences in patients receiving slightly different messages. Again, that kind of helps with any queries that may come through to the reception team. So actually, you know that the message that has gone out is requesting for a patient to drop in their urine sample and their blood pressure readings. That's absolutely fine. It will be the same message across the board. So it's a much better experience for patients, but it really, I mean, it hugely reduces the amount of admin time spent on our side without having to kind of create all of these separate messages, without also having to schedule those messages in a week or 2 weeks' time to remind the patient to book in an appointment and get that second invite out to them. So if we can go on to the next slide, I kind of wanted to touch upon what my sort of positives and wins are, because I think I'm sure you're all thinking, oh, how will this work? Is there kind of any wins for me? Actually, we do all right with QOF, so is this something that we really want to do? I think there's like some key wins that I've really seen. So bulk recall, huge. I think moving kind of towards bulk recall to ensure that you are capturing people either via month of birth. Currently, we're combining month of birth and risk. So actually, that means that I know at the end of the month we have recalled all patients that are going to be most appropriate for that, especially looking at the capacity side of things. So actually, I've got this many appointments. How many people can I recall? Does that mean that I can recall earlier? Get all of our recall done before Christmas. So QOF Complete by Christmas, yeah, it is definitely something that is doable. It means that we can work at that kind of cohort level rather than patient by patient. One of the biggest things is this pathology work that Amy has kind of shown you guys. So from my perspective, this has gone from realistically for a patient, let's take, for example, with the practice that I'm working with, I would say 5 minutes for somebody to log on to the patient, check the blood test analyzer, check to see any medication monitoring that's needed. And that would tend to be a pharmacist or a pharmacy technician doing that, not necessarily a care coordinator, going on to ICE, requesting the bloods, sending the text message, potentially uploading the form as well. This now, as by using bulk recall, we can do that in a matter of minutes for 50 patients. Huge time saving. So I think that's definitely something to bear in mind. Another thing for me is kind of having the right people on the right tasks. So actually care coordinators, from my perspective, they can now really take a lead in recall work. It frees up the clinical time for GPs, for nurses, for pharmacists, for pharmacy technicians to actually have that clinical time back and deliver the clinical care that will help you ultimately hit all of those QOF targets. So that could be that actually I'm going to ask the care coordinators to request all of the bloods and to recall for next month. That means that I can actually start to review some of the blood pressures that are coming back. I can potentially do some reviews. It frees up our nursing staff to be able to actually have more appointments. Does that mean that we can organise more home visits? Does that mean that we can actually do some more outreach, especially taking into account some of the neighbourhood work? So that's a huge thing for me, of being able to move that task over to care coordinators. Something that I think is really important, and I know that there's been quite a few questions about this, the medication monitoring searches, which are CQC driven, planner supports that and will request those bloods if they are required. So again, previously, CQC work that has been picked up by other clinicians, so that could be pharmacists, pharmacy technicians, nurses, doctors, actually that can now be picked up by care coordinators. So with that in mind, we're seeing more complete care and fewer missed investigations for patients. And I think one of the things that we can kind of really champion is having everything in one place. It removes a lot of the manual effort. It removes the pulling of reports. It also takes out the need for everybody to have full population reporting permissions, to have access to Arden's manager, to have all of these different accesses to information, where actually, I mean, I hold my hands up. The first time I was shown population reporting, I thought, oh, I don't know where to start. Actually having all of that information there, having it really clear on planner of this is what these patients are waiting for, this is what they need, it definitely kind of removes that. And I would say, like, kind of, I guess, to finish from my perspective, it's made recall really scalable in a way that it just wasn't before. It means that I can now look and say, next year, so from last year to this year, we're in a far better place. The more we kind of get used to using this, the more efficiencies that we can see in the time saving. It all kind of builds up to ultimately deliver better care for the patient, which ultimately we're all kind of here for. That's one of the things that is most important to us. Completing QOF, fantastic. That's obviously got its positives, but ultimately we've got a patient at the end of the day that we want to make their care kind of as best as possible. Yeah, so I guess that's kind of everything that I wanted to add. So I will hand back to Will now.
Amazing. Thank you so much for your time, Chloe, and for sharing all of that. And like I said, we wish you all the very best in hitting that QOF by Christmas. So for those on the call, we'll check back in later on in the year to see how that progresses. We'll just very quickly round off with just a few very quick things. If you do need to hop off, please we respect your time. So we will send across some of the questions that have come through the chat. This is a free tool for you all to use as well. It's called the Forecaster. It links in with the planner. It shows you all of your year-to-date performance. And so you can now start to track your targets throughout the year and actually go from what we call helicopter view down to patient view in as few clicks as possible. So what you're able to do now is move from the world of, as Chloe mentioned, multiple tools into one seamless experience. So that is all free for you to use, and we'll send out the links to that afterwards. And yeah, I think I will say, as someone who obviously is working in a lot of this space, is that whichever tool you do go for, we really recommend actually having that process, because with that kind of neighborhood transition, we are getting signals that really being proactive in your provider and really demonstrating that you have a clear grasp of your patient cohorts will stand you in really good stead for the neighborhood transition.